Our second two sets of presentations are on the role of nutrition in Alzheimer's disease and nutrition for patients with dementia. The first speaker is Dr. Nabeel المعلمي. Dr. Nabeel المعلمي is an assistant professor of family medicine. He's a consultant of geriatrics and palliative medicine. So welcome, Dr. Nabeel, and looking forward for your talk.
طيب السلام عليكم صباح الخير. بسم الله الرحمن الرحيم والصلاة والسلام على سيد الأنبياء والمرسلين سيدنا محمد وعلى آله وصحبه أجمعين. أما Good morning, everybody, and thank you for giving us time to the weekend. Today I'm going to talk about feeding issue in dementia patient, and I would like to thank the organizing committee for their kind invitation. So I don't have anything to disclose, and we're going to talk about feeding issues in dementia patients. So we're going to talk how common is it, then the impact of this issue, causes and evaluation, how to assist those patients, the management, and the common question, oral versus tube feeding. Then we're going to give some messages to take home later. So in early dementia, most of the patients are sitting at their homes with their families. Most of the time, we don't have statistics about how common is the feeding issue there because they don't express that. One of the issues is that they cannot afford the food. They cannot know how to make the meals. However, we know that weight issues are very common in these early dementia patients, around 20 to 45%, depending on the setting of your study. Thank you. Then we come to patients that are admitted to long-term cares and advanced dementia, and feeding issues are very common, as you know, around 30 to 60%, again, according to your setting of the study. And although that is a very common issue that we monitor, but assessing patients for weight loss and nutrition are usually lacking in our clinical practice in day-to-day when we see our patients in the clinic. One of the studies that was done by Dan Lin and colleagues, they look into the low food intake in dementia patients and they look into the causes. One of the commonest that increased the likelihood for patients to have weight loss and not to be fed well was feeding issue, about 20% odd ratio, or 20 times the rate to increase their likelihood to not to be fed well. So that will lead to insufficient food intake, weight loss, dehydration, and aspiration, admission to the hospital, ICU, and most of the times die alone in the ICU, unfortunately. This study was done in 2009, and they looked to patients that were admitted to long-term care in the United States. And as you can see, since admission, they noticed that the patients have eating problems. And with increasing of the frequency of the eating problems in these patients, there was increasing the likelihood of patient to aspirate and also to die later on due to aspiration pneumonia and febrile illnesses as well. So the main causes of feeding issue in our dementia patients are mainly in 4 causes: oral dysphagia, where patients are bucketing the food in their mouth, and pharyngeal dysphagia, where they're unable to swallow. That's why we advise all the caregivers to monitor the patient when they take the food, make sure that they can chew it, they can swallow it well. Then they have inability to perform the task of eating. They forget how to do it, or they forget something related to food, how to prepare their meals, how to eat. They don't able to smell sometimes, as we talk about later on. And depression, which is really difficult to assess in demented patient. And these can be elaborated more when you can see that we know that dementia patient will have less smelling, taste will be decreased as well. They have other problems with reduce the sense of thirst as well. And that's why we're going to talk about the management and how to tackle it. We're going to talk how you can verbal cueing to these patients and encourage them to increase their intake. So early diagnosis is one of the keys to tackle this issue. So a thorough assessment for these patients have to be done by multidisciplinary team members. It doesn't have to be just by the physician. So you have to involve your dietitian with you to assess the nutritional needs for your patient. Also, one of the important team members is the speech therapist and a swallowing specialist, where they should be included as well to assess the swallowing of your patient. Also, the occupational therapist to assess the patient need for utensils and these things, and also the social worker to assess the social needs of your patient as well. then usually you have to always assess the patient regarding reversible causes. One of the commonest is teeth issues or tooth issues. And as you know, most of our patients will have dentures. And when they lose weight, most of their dentures will be not fit as usual. So you have to assess very well for causes that can be fixed. If they have akramakumullah constipated, if they have anything that can reversible easy, then should be tackled in the beginning. Another important thing to do that we have to assess our patient, especially in the hospital, regarding feeding issues. And one of the models that we use to unify the assessment is using a validated tools. And there is fallible tools. The Edinburgh one is the most common that used worldwide, and it's been tested in multiple cultures. And there's also the feeding behavior inventory and the feeding difficulty index as well. Usually it has to be performed by one of the multidisciplinary team members with you, and you should score the feeding difficulty for your patient if it is admitted or even if they are in the outpatient. The Edinburgh feeding evaluation, in the beginning it was 11 questions. Later on it became only 10, and you have to score it by 0 or 1 and 2. And depending on the scoring, if the patient score 11 or more, then they should be assessed regarding feeding. So you should assign somebody to help them regarding the feeding. And the more score is higher, the difficult the patient to be fed. As you can see here, that at the beginning when refused to eat, they refuse to open the mouth, and things get worse till the patient is just leaving their mouth open and is not responding to verbal cueing to take their food. So what is the management that we have? So I'll talk first about high-calorie supplements, and there's multiple studies done, and it shows that it can increase the weight, but unfortunately it will not improve anything in the prognosis of, in the prognosis or improvement for the patient nutritional status itself. The other thing is appetite stimulant, and the most common is migstrol acetate. And as you know, there is a recommendation from the AJS and all the BS criteria that should not be used in elderly. The other one is the cyprohydrogen as well, and also we don't recommend that. Sometimes in palliative we use the dexamethasone, and usually we use it just for limited prognosis patient. And it is effective, but however, as I said, patients that are prognosed within weeks, a month, but not for patients that are still have some time in front of them. The other thing that you can do for early dementia patients, you can alter the texture of the food, offering finger foods. And alhamdulillah, in our culture, it is acceptable that patient can eat by their hands, which can add another sense for the patient for the food. A smaller portion, present them with their favorite food, and nutritional supplements, as we said from before. So anyway, increasing the type of stimulation that you have, you can add more taste to the food by using like sauce, or you can add other spices that make the food more spicy and more tasty. As we said from the beginning, that the taste of sense is decreasing in our dementia patients. The other you can do that verbal cueing, and sometimes you can do it as indirect, where you can ask the patient or your loved one, how does the chicken taste? How is your sandwich? Do you need another bite? Did you taste your drink? Just verbal cueing. Physical assistance, sometimes hand-on with the patient, where you hold their hands and give them the bite. Socialization, try to take your food with your loved one, with the patient, when it is the time for the food. Also snack assistant, if the patient is not really interested in food or walking around most of the time, you can just walk with them and offer them a snack that can help with increase their intake as well. So despite all of that, we know that still feeding will not be enough, and a patient will have more feeding difficulties. And this is when the patient goes more advanced. Then you have two choices. Either you continue the oral feeding or you go through the tube feeding. So the preferred choice for all medical society that are talking about geriatric patients are to go continue oral feeding. And the choice is that regarding a lot of study that done through the years. And the main goal is to provide comfort even to the patient. We know that even if you give the patient oral feeding, It will not improve their weight a lot. Their survival will not improve. However, socializing with the patient at the time of the meal or your loved one will give them more joy and will help them to have some quality time with their family members or with their caregivers as well. So the strategy as well, when you have the patient in advanced dementia, you should minimize the distraction as much as you can. Sensory clues, if you have bright color plates with white napkins, more colorful food, one type of food at a time, optimize the patient positioning or schedule the meal as well at the time when the patient is more alert and awake. So tube feeding, and I think this is one of the big questions for all of geriatric. Do we go with the tube feeding or not? So there's a lot of studies that look at evaluation of the tube feeding for a dementia patient and the effect of that. And one of the studies was done by Samson and their colleague and showed there is no evidence of increased survival in patients with tube feeding. Quality of life was not improved, healing was not improved. But even with that, all the studies were observational studies. There was no randomized controlled trials. So there is no strong evidence trials to tell you that this is not happening. There is now some recent study that show some changes, but we'll see it in the future if it's going to change most of society opinion about that. Another, they look at does the feed tubing improve the patient, the timing when the patient inserted to long-term care or not. And at that time, sorry about the slides, there was no difference was found in survival between the two groups, whether the patient was receiving tube feeding or oral feeding. The survival was the same. And so the conclusion was against tube feeding as well. The problem with the tube feeding, if you are familiar with that, patient will have tube dislodgement, blockage, and leakage, aspiration, pneumonia, a lot of visit to the ER, where the caregiver have to take them each time to the ER and come back home if it need to be done or not. Agitation, as you know, most of the demented patient will try to remove their big tube. And as I said, most of the geriatric societies, the European, the American, the Canadian, they prefer continue oral feeding versus tube feeding. One of the important things, whenever the family insists, I think you should sit with the family as a multidisciplinary team and explain to them the consequences and the benefit of such intervention. And try as much as you can to show them the benefit and the consequences, and guided by the patient wishes if you have anything that you know about. So in the end, feeding issue in dementia patients are very common, and always assess the patient for reversible causes. Oral feeding is the preferred method that should be given to our dementia patient. Thank you.